Precocious puberty is a common presentation to the pediatricians and often presented as a diagnostic challenge. A comprehensive understanding of physiology and pathology and its interaction is essential to achieve a successful outcome with regards to evaluation and management. Recently, we saw in our outpatient this 11-year-old girl who presented with complaints of short stature and already had fused epiphysis. Now, this girl importantly had presented at the age of approximately 6 years with breast development, and at that point of time was reassured. And unfortunately, by the time the child came to us, she had such a compromised height that there was no further outcome possible. So precocious puberty is a scenario which is definitely common, much more common in girls as compared to boys. And it's important to understand that while most girls have a physiological cause, a pathological cause can happen around 40% of boys and 10% of girls. This really highlights the importance of not doing undue workup in individuals who have physiological form while not missing those pathological causes. Talking about the what, when, and how of precocious puberty. All of you can go and have a look at our website, learning.growthsociety.in, which has got a lot of resources related to pediatric endocrinology, including precocious puberty. From a pathophysiological perspective, pubertal regulation involves the three major organs, the hypothalamus, pituitary, and the gonads, and the three major hormones, GnRH from the hypothalamus, gonadotrophins from the pituitary, and the sex hormones, estradiol and testosterone coming from the gonads. The abnormalities which may result in the development of precocious puberty may come right from the hypothalamus, which is the central precocious puberty characterized by an elevated level of luteinizing hormone. This form of puberty is associated with enlargement of testicular volume, which is the most important sign of precocious puberty and sight in boys, and a concordant pattern of a breast development followed by vaginal bleeding or menarche, which happens approximately around 2 years from the onset of thelarche. They could also have a large number of idiopathic forms, but as discussed, boys and girls younger than 6 years have a higher chance of having an organic pathology of central precocious puberty. There could also be an increased production of androgens via the adrenals and the testes, or estrogen via the ovaries, which will result in what is known as peripheral or gonadotropin independent precocious puberty, which is associated with a LH level, which is significantly below the detectable range. These forms of precocious puberty in boys are easily identified by the small testicular volume, and in girls by the discordant pattern of pubertal development, where significant amount of estrogen causes a sudden increase in breast development, and menarche or vaginal bleeding, which happens pretty close in a discordant pattern, less than 1 year difference between the breast development and the vaginal bleeding. Precocious puberty in girls, as discussed, is usually idiopathic and a common variations, and often they tend to present with incomplete forms of precocious puberty, which include thelarche, pubarche, and menarche. Importantly, if there is isolated vaginal bleeding that indicates a local pathology like trauma, tumor, or abuse, in which a gynecological workup is required. Complete precocious puberty is largely central, which again is idiopathic in most cases, around 80 to 90% cases. But early onset presentation with neurological features should evaluate for possibility of a CNS lesion. Very early onset with family history, possibility of a genetic cause, and we also need to evaluate for all possible CNS insults which can cause precocious puberty. Peripheral precocious puberty represents increased estrogen production by the ovaries, largely coming from the ovarian production using the McCune-Albright system pathway or hypothyroidism, where the TSH binds to the FSH receptor to cause increased production or an ovarian cyst. Very rarely do we have adrenal tumor or excess estrogen production. So largely, we are dealing with a garden variety, central precocious puberty, which is idiopathic. And if you have a girl between 6 to 8 years with that presentation, always be wary of a slowly progressive puberty in which the menarche is delayed. There is no need for evaluation and urgent treatment in that regards. The key questions here are, is it really precocious puberty? If it is precocious puberty, is it complete or incomplete? And finally, what's the cause? The precocious puberty is defined in girls by onset of either the pubic hair or the breast development before the age of 8 years, Important thing here to remember is that we should not confuse lipomastia or fat enlargement with a true pubertal development, and early pre-sexual hair development may be normal in this scenario. Very importantly, there could be a vaginal bleeding which is happening before 9.5 years, and that also is considered precocious in that regards. Very importantly, as discussed, we should consider the physiological variants like neonatal breast development, which is because of a transplacental passage of estrogen, lipomastia, which is characterized by the fat deposition around the breast area. It can be identified by approximating the thumb and finger. If there is no resistance between the two, it suggests lipomastia. And finally, we can have isolated labia hairs which can come in infancy, which may be a normal variant in that perspective. So we'll start off with the cases. This was a 7-year-old girl with thelarchy. She had stage 2 development. Her height was normal, referred to us for evaluation. She already had a bone age which was normal. The gonadotrophin levels were also normal in that regards. The vaginal mucosa, which is a marker of pubertal status, was red, which suggests that this was more like a pre-pubertal state. So when we did a careful examination, we found this was not really a precocious puberty. This is lipomastia, a common condition which is encountered in obese girls. So don't get confused with that. Don't label it like an actual precocious puberty and work up in that regard. Now, importantly to remember how the hormonal progression happens is that there is a substantial elevation in LH across the pubertal stages. So the LH levels may actually increase significantly over this period, while FSH are a more unreliable marker in that regards. So LH is the best marker as far as pubertal onset is concerned. Very importantly, there is also a greater rise of the bioactive LH over the immunoactive SH. So we need to look for LH as the key marker of onset of precocious puberty. So a LH level above 0.3, GnRH agonist stimulated LH of 9 below 3 years of age is considered the confirmation of puberty, while levels which are above 0.2 and stimulated levels above 5 between 3 to 8 years are considered markers of pubertal onset. Also, a substantial change which happens with regards to the pubertal onset and the reproductive organs. The most important marker is the change in uterine shape from a tubular structure to a globular structure, along with increase in uterine length from 32 millimeters to beyond that, and an increase in volume beyond 2 ml. So these are the markers that the individual has entered puberty. Approach to a girl with precocious puberty depends upon the features that we are looking at. If a girl presented to us largely with precocious pubarchy, we have to assess the DHEAS levels because that will tell us the severity of presentation. If the DHEAS level is below the pubertal range, this is isolated pubarchy, usually a benign condition, does not require evaluation. If the DHEAS level is between 40 to 135, this suggests that this is premature adrenarche, particularly common in the setting of small for gestational age babies with rapid catch-up. This could be a forerunner of metabolic syndrome subsequently in life. However, if the DHEAS level is more than 135 microgram per DL, this could be a sign of a sinister pathology wherein we have to look for other causes like congenital adrenal hyperplasia as well as an adrenal lesion. Individuals who have a high DHEAS should undergo a 17-OHP. If 17-OHP is low, we should exclude an adrenal tumor. If it's borderline, we should do a ECTS stimulation test, while if the levels are high, we should diagnose it in the setting of 21-hydroxylase deficiency. Girls who present predominantly with isolated vaginal bleeding are more likely to have a local cause of precocious puberty, and they do not need extensive hormonal investigations. What we need to do in that scenario is to basically get a gynecology referral to rule out trauma, tumor, abuse, or infection. Girls who present with a complete progression or with thelarchy need evaluation for the rapidity of progress. An important factor here is to look at a bone age. If the bone age is retarded, every girl with precocious puberty should be tall and should have an advanced bone age. So if the bone age is retarded, we should consider the possibility of hypothyroidism, and evaluation for the thyroid profile becomes important. If the bone age, on the other hand, is normal, it suggests a slowly progressive form of precocious puberty, a condition which is now increasingly being encountered, and this may just need observation. However, precocious puberty with advanced form and elevated LH suggests a central form of precocious puberty. In this scenario, a routine neuroimaging is not required. It is reserved for individuals who are below 6 years or those who have a neurological manifestations like raised ICT, headache, or vomiting. Individuals who have a prepubertal LH should be evaluated for peripheral forms of precocious puberty, particularly with an ultrasound in that perspective. So the evaluation of a girl with precocious puberty depends upon the extent. Even if they are presenting with pubarchy, look at DHEAS and then go from there. If it's isolated vaginal bleeding, look for local cause gynecological referral. If there is thelarchy, bone age will be the major guide to assess that in that perspective. Now, coming on to these cases, this is a 2-year-old girl who presented to us with thelarchy, and the further evaluation was done, which looked at there was a history of 6 months ago. This was a slowly progressive form of precocious puberty, stage 3 breast development, no pubic hair development, and no period. Now, this is a very common presentation of what is known as isolated thelarchy, which is largely related to the mini puberty, which happens in which there is a slight increase of estrogen. The condition is benign and self-limiting. All you need to do is to have a basic evaluation of the growth parameters, look at the gonadotropin levels, the estrogen levels, and what we see here is that all those levels are low. FSH may be slightly higher as discussed because FSH levels tend to be higher prepubertally, and in this scenario, this is classically isolated thelarchy. Ultrasound may show small cyst, but nothing is required in that regards. We just need to follow up over time and things will improve over time. So a young girl presenting with just breast development with a prepubertal LH, follow up, don't do too much in terms of further evaluation and work up from that regards. However, similar scenario, 2-year-old girl with breast development and now vaginal bleeding who had thelarchy 3 months ago. So there is a very limited gap between the breast development and vaginal bleeding that we are seeing here. The girl looks a bit tall. There is no pubic hair development. Importantly, there is stage 3 breast development and the vaginal mucosa is pale, which is basically a marker that there is a estrogen exposure which is there. The further step here would be to look at the bone age, which was found to be advanced. Further workup showed a completely suppressed gonadotropins with a high estrogen. So this pattern of discordant pubertal development, rapid breast development followed by bleeding along with advanced bone age suggests a possibility of a peripheral precocious puberty, and in a very early age we have to look at it very carefully the cutaneous manifestations. And what we found here was there was a ovarian cyst on ultrasound and there were multiple cafeole spots suggesting a McCune-Albright syndrome. So very early onset discordant pattern of puberty, consider McCune-Albright syndrome as a possibility. 1.5-year-old girl with menarche. So again, a very early onset of breast development. Breast is just stage 2. So it looks like a bit discordant here in that pattern. Height is slightly advanced. The further workup showed a LH which was significantly elevated. So compared to the first girl who only had breast development, the LH was completely suppressed. Here the LH is on the higher side. And we said that if the basal LH is more than 0.3, you start getting worried about the likelihood of a pathological cause even at that age group. So this is a very early onset. MRI was done, which showed a lesion which is known as hypothalamic hematoma, which is a normal tissue in the abnormal location. So this is not a sort of a neoplasm. This is a normal variant. You don't need to do any sort of surgical intervention. All that is required is to follow up in that perspective. So very early onset, central precocious puberty in girl, think of a hypothalamic hematoma. Now go to the other aspect, 1-year-old girl with pubertal development, onset 3 months ago, which was again a slowly progressive course. In that regard, there were only some labial hairs, 1 or 2 labial hairs were noted. There was no hair in the pubic area. So normally we get very worried about this scenario that there is pubic hair development happening so early. Remember, this could be an isolated pubic hair of infancy, which is a physiological variant. So all you need to do is to look at the DHEAS level, which were found to be normal, and we just need to observe. So very early onset of pubic hair in young girls If it's not associated with clitoromegaly, not associated with other features of virilization, we can just observe and manage from that regards and perspective. 7.5-year-old girl with pubarchy. So now we are moving towards the older age group. Birth weight was less. So this was a small for gestational age baby. The girl looked a bit tall and definitely was in the overweight obese range. Weight was high. She had stage 3 pubic hair development, no breast development, and no period. So this is isolated pubarchy. And as we had discussed, if you have a SDA child, they have a rapid growth. There is a risk of insulin resistance, which triggers this form of precocious puberty. So if you have a girl like this, you should do a DHEAS, which was found to be in that premature adrenarche range. Testosterone was not high. So this is most likely that rapid catch-up scenario that we are looking at. Bone age is slightly advanced. The best thing to do here would be to follow up carefully, and this could be the forerunner of metabolic complications, diabetes subsequently, and therefore we need to be bothered about that. So follow-up will be the best strategy in that perspective. 6-year-old girl with pubarchy, so it's a slightly earlier presentation than this case. Again, the birth weight was normal, so this doesn't look like a SGA. The height is definitely more advanced. There is no obesity. So tall girl with the precocious pubarchy, which is again stage 3. Now, next step would, of course, be to look at DHEAS. And what we are seeing here, the DHEAS is very high. So this is a pathological form of precocious puberty. What we need to do is to look at the bone age, which was advanced, and look at 17-hydroxyprogesterone, which was on the higher side. So this is classically suggestive of CAH in that perspective. So again, if you have an earlier onset of pubarchy, if it's more progressive, in a non-SCA child, very important to consider CAH as a possibility, because that can have significant implications in that regards. 7-year-old girl with vaginal bleeding, and again, an interesting scenario. There is no breast development, no pubic hair development. So this, as discussed, is not an endocrine cause. This is suggestive of isolated vaginal bleeding. In that scenario, we have to consider for a local cause. So what we need to do is to look for the vaginal mucosa, which was red, which means that there is no estrogen exposure. The LH and FSH levels were suggestive of a prepubertal stage. Estrogen was low. So this is more like a local cause, trauma, tumor, abuse in that regards. And when we refer to the gynecologist, want to have a foreign body. So isolated vaginal bleeding in a girl is suggestive of a local cause and not an endocrine cause in that regards. 6.5-year-old girl with menarche, again, early onset. Last 1 week, she had thelarche, and suddenly she had this vaginal bleeding. Again, discordant, and she is not tall. She looks like short in that perspective. Very importantly, there is only minimal breast development stage 2. There is no pubic hair development. There are no cafe au lait spots that can be seen. So it goes against McCune-Albright. So this looks like a discordant pattern here. The LH and the FSH levels are low. Estrogen is high. So we have a scenario in which there is peripheral precocious puberty, discordant pattern, undetectable levels of LH and FSH. So we need to do imaging in that regard. And what we found was ovarian cysts which were there. And what we did in that scenario was just to follow up. The workup for hypothyroidism was done, which was normal. And over time, this functional ovarian cyst resolved. So if you have just a small breast development, and which looks like a transient phenomena, this may often be a withdrawal bleeding, and over time they'll become normal in that perspective. Another interesting case, 7-year-old girl with thelarche. She had breast development for 3 months, very short. Now, as discussed, everybody who has precocious puberty should be tall. This girl was short. Pubic hair stage 1, no pubic hair, stage 3 breast development, and there was a pink mucosa in the vaginal area which suggested that there was an estrogen exposure in that regard. So this girl is short with precocious puberty. Further evaluation showed a large ovarian cyst. So as discussed, every girl with precocious puberty should be tall. If you have a short girl with precocious puberty, think thyroid. So further workup was done which showed a retarded bone age, and there was significant elevation of TSH. And it is this TSH which acts on the FSH receptor to cause ovarian cyst and precocious puberty. The condition is self-limiting and improves with thyroxine supplementation. You do not need to do extensive management or surgical intervention for ovarian cyst. This all will resolve in that regards. Coming back to the original case, the girl actually had presented a 6-year-old with the thelarchy, and then she had a compromised height. So if there was proper evaluation was done, we would have known that there is breast development, bone age is advanced, and there is a central pattern of precocious development, and this would have been an ideal case for GnRH analog. So GnRH analog therapy are the best modality to treat central precocious puberty. They are indicated in all girls who are below 6 years of age, and between 6 to 8 years, we need to decide whether it's a slowly or a rapidly progressive form. So if you have an advanced bone age, if there is compromised adult height, those are the indications when you should consider treatment with GnRH analog.